Animalar Medical College and Hospital Research Institute, Chennai, Tamil Nadu. And the topic he'll be covering today is analyzing medication errors and case discussions. Welcome you, sir.
Yeah, thank you for your kind words. So, good evening, everyone. So, am I audible?
Good evening, sir.
Yes, sir.
Yes.
Okay, guys, I hope everyone is not hungry and have some time for the session. So, I'm going to share the things which you have studied frequently in your class from hospital posting. But let me check how any person who is working as a clinical pharmacist attending the session. Can you hear me? So is my screen visible to everyone?
Yes, sir.
Yes, sir.
Yes, sir.
Okay, guys. So our
Yes,
topic
sir.
it is analyzing medication errors and case discussion. So may I know how many persons working as a clinical pharmacist in a hospital setting? So you can put your response in the chat box so that I can get some idea. Are all of you are students out of 130 members approx? Why? Because why I'm asking it is a medication error. It is a very broad topic. So if I'm telling it in a very overview manner, or if I'm taking it to the depth, it will be very hard for you guys to take a follow up or grab the things. So I just want to know the people, and it means I just want to know the audience so that I can present accordingly.
Sir, I am a student, sir.
Okay.
Yes, sir. I am working in sir hospital and at a consultant, sir.
Okay.
Yes, sir.
So okay, guys, without any delay, I'm okay. Any interns?
Yes, sir.
Yes, sir.
Okay, okay. Okay, guys. So, as anyone can tell about one line or what you know about the medication error which you have dealing in your hospital rounds or as a working professional. Any one of you, either in the chat or either it is a wrong or right. If you are come forward, you will be grab most of the things and the session will be interactive. Or else it will be like taking some presentation in front of our classmates and leaving it. It won't be that much effective for both of us. Anyone? So you can pass the comments in the chat box.
Mistake in dosing.
Okay.
Not
Any
reaching the
other?
therapeutic outcome.
Mistaken route of admission.
Okay. Well, good. It is you people are telling every part about the things you are observing. It is good. Any other one?
Sir,
Okay,
dose and
guys.
dosage forms may be mistaken, sir.
Okay. So, but
Or
you
mistake
people.
in
Yeah.
drug names.
Okay.
Making a mistake in look alike and sound like.
Okay. Good. Next. If anyone
Not
is
reaching.
having that collectively, you can say that thing. So if people telling everything, so which is going to come under the medication error, what we're going to discuss further. But I just want anyone can give a 2 to 3 lines about the medication error.
Not reaching the therapeutic outcome because of some internal mistakes.
Okay. Any others?
Medication errors are any type of errors that occur from prescribing, transcription, administration.
Okay.
of drugs to the patient. Yes.
Okay. Okay, guys. So it is good. You people have some idea about the medication error because we are the peoples who is expert in medicines. But before dealing with the medication error topic, you people should aware about the one thing. We are the people who can prevent the drug injury for the patient because any of the drug which is available for the treatment of the patients, which is can treat the patient in a wise manner. If it is used any of the either it is
Sir, you are not audible, sir.
Not audible.
Sir, your mic is muted.
guys, sorry, my network is have some issues. Hope I'm audible now.
Yes, sir.
Yes,
Okay,
sir.
okay. Yes, guys, though that I'm telling you, so either first of all, the patient is coming to the hospital. The patient will be having basic issues. Either the patient will be in having the metabolically compromised or immune, what can I say? The patient is immunocompromised or some other issues. But if the drugs or the treatment it is not handled properly, it will worsen the patient condition. First, in the first case, it will worsen the patient complication and the condition, and it will increase the hospital stay. It may lead to the metabolic complications, so many things. But in this, as a clinical pharmacologist, so we are playing the major role, but we are the people
Sir,
should have the up-to-date knowledge. Yeah,
screen
yeah,
showing
Anurag.
some window.
Window.
Sir, screen showing some window. Not clear
Screen
PPT.
is. Oh, wait, 1 minute. I will reshare it. Is now my screen is visible to everyone?
Yes.
Okay.
Yes,
So
sir.
I'm
Yes,
telling
clearly
you,
showing.
so medication error, it isn't any preventable event that may cause or lead to inappropriate medication use or patient harm, while the medication is in the control of the healthcare professional or patient or a consumer. So the medication error can happen in the inpatient setting or OPD setting, or it is dealt with an OT setting also, either under the supervision of medical practitioner or a nursing professional, any one of them. So it is the definition which is given by the National Coordinating Council for Medication Error Reporting and Prevention. So it is started in the year of 1995, which is having the more than 20 countries, national councils along with this. So types of medication errors. So it is a very basic thing. You guys may aware about these things, but while starting from the basics, I'm giving you the overview. Prescription error, transcription error, dispensing error. If you are a hospital, there is an indenting system. So indenting, nowadays most of the hospital they are having the indenting. Either it is by done by nursing staff or some of the hospital they are doing. The pharmacists were doing this particular indenting role. But after that, administration error, monitoring error. So these are the major 6 errors which is happening in the hospital. But in everything it is, we will be having that so many subclasses. But again, this National Council for National Coordinating Council for Medication Error Reporting and Prevention, it is categorized the errors. So according to its severity, though how it can harm the patient. So here I have displayed the things. So category A. So it is circumstance or events that may cause the capacity to. So the circumstance or event that have no capacity to cause error. So that was a while cropping the image it went, I guess. So it no capacity to cause the error. So example it for it is, I'm showing you there, guys. The I have examples. Are you able to see the prescription over here?
Yes, sir.
Yes, sir.
So if you are seeing here in the screen, so injection, last one, the third one. So injection omega 1, it is 100 ml it should be, but it is written as an 100 L IV OD, but it is not legible at all. So if someone is seeing either the person who is intending the medicine or the person who is administering the medicine, that particular person will get confused. There is a chance for administration error. So this error, even though it is doesn't have any things, but you need to understand, I have mentioned that no capacity to cause error. That kind of error, it is second one. Pure trace acid. It is they have mentioned, but the dose should be mentioned, but they didn't mention the dose. But one sachet they have mentioned because it comes in a sachet. So the patient will be receiving one sachet. So that particular thing, it is an error, but it doesn't have the capacity to cause an error. So since the dose it is clear for every drug, we can't mention that exact dose. So if we are example, I'm giving you guys, it is in 5 grams. So while we are seeing the label, we can identify the things. But in some, if while they are writing the exact brand, right? So there is no, if they are not mentioning the dose, the only particular dose is available in the particular brand, it is not an actually error. Because while we are seeing the prescription review, we will be telling that everything it is an error. So, but we need to understand that. And another category, category B, it is an error occurred, but the pay, but the medication error didn't reach the patient. Okay, an error occurred, but the medication error didn't reach the patient. Here, the pharmacist or the person who is auditing on a regular basis, we are as a barrier between the prescription to administration or from the administration to the another harming the patient. So we are playing a role. So if you are seeing this as an injection omega when as an 100 L, so we can tell to the physician to rewrite the order, because if the overrating they are doing, so it will confuse the particular nursing staff again and again. Okay. And in category B, the dispensing errors, if they are dispensed the wrong quantity of the medicine, so that will be coming under the category B. And another thing it is, if they are mistakenly mentioned, so injection pantoprazole BD. So okay, I'm just want to ask you guys, injection pantoprazole BD for a normal patient, is it a rational prescription? Can anyone you answer? Any one of you? And you
For
should
a
tell
normal
that.
patient, it is irrational, right?
So what is the reason behind that?
The duration of action is 24 hours. The onset of action.
Duration of action, it is 24 hours. Are you sure?
Yeah. It's given once a day.
Because we need, whenever we are telling something, so we need to, but your answer is half right, but it is what you have told, it is not. So you have told 24 hours, right? But you have told
Yes.
that half-life, how many hours it is for the pantoprazole? Can anyone? So no issues. Kindly, if you are telling right or
Sir,
wrong,
1 to 2
so
hours.
what? I didn't get you.
1 to 2 hours.
It is 1.1 hour. It is correct only, but I'm telling you guys, if you are telling to anyone physician, or you should be more specific. So you have someone give the answer 24 hours, right? Who is the person?
Yes, sir.
So first of all, your answer is half correct, but you should be more specific. So what is the reason behind that the 24 action? Because the pantoprazole action, which is produced by the pantoprazole, it is half-life, it is one hour only. So in an average, it is 1 hour. But the action produced by the pantoprazole, so which inhibits the gastroparietal cells, K plus cells, which is inhibited by the pantoprazole. So that action, it is irreversible for 24 hours. So the action produced by the pantoprazole, which is irreversible, but that's why the acid secretion, it won't be there for the day, giving the so okay, if the what will happen if they are administering the another dose for the patient, and can anyone can answer that thing? Okay, the patient is we are all know that the patient is receiving pantoprazole BD. So first action itself, it produces the action which is more than sufficient for the 24 hours. So what will be happening while they are administering second dose of the pantoprazole? Can anyone in the chat box, guys?
Overdosing?
No? Anyone?
Rebound acid secretion.
I didn't get you.
Rebound acid
என்ன
secretion.
பண்ணலாம் மண்டே கூட வர சொல்லி
No. Guys, it is a simple, because you guys should understand that one thing, receptor saturation will be there. Because one particular drug, it is by action, it is produced by the one action, it is produced. So for that impact, it is the particular conversion, it is irreversibly inhibited. So that drug will be in that particular site, so that is producing mimicking the action. So that if the another drug which is administered to the patient, so it can't bind and produce the actions again. So but I'm telling you again, injection pantoprazole BD, it is rational for some patients. Can anyone of you name the condition? In the chat box, if you are not comfortable to unmute yourself, you can put it in the chat box. Guys, come on. It was going interesting. And I'm already running out of time.
GRD.
Yeah, it is correct answer. Why? Because in the GRD, that smooth muscle, it is having that effect to reflects the things which is present in the stomach. So what is the reason behind that another dose? Because we have discussed that it is the action, it is already produced by the GRD. So which is produced by the pantoprazole. It is already receptor, it is saturated. The action, it is irreversible. So what is another dose of pantoprazole will do? Simple pharmacology are the things can help you out, guys. So I'm giving you the answer in the screen now. So okay, that one line it will be more than sufficient for all of us. So our esophageal sphincter muscle tone it will be reduced by the proton pump inhibitors. It is in secondary action. How that cetirizine it is action it is produced as a secondary effect of sedation. So it is in secondary action of an proton pump inhibitors. So that's why it is working for the GERD conditions. Hope you people got it.
Yeah, sir.
And another thing it is, so you might have seen that some of the patient in ICU, so they will be giving the pantoprazole infusion. Is there any rational use of the behind that, or is there or we can give a pantoprazole infusion in any condition as you, in your experience, guys? One. Okay, I'm giving you the answer. So unless otherwise the patient is having metabolic acidosis, so the patient is not recommended to start with the pantoprazole infusion. So in the metabolic acidosis, you can ask me, sir, that acid secretion it is stopped. So and what is the use behind that? But when the patient is having metabolic acidosis, so in order to excrete the neutralize the amount acid which is present in the patient's stomach, the continuous infusion it is given up to 2 to 4 days. So that condition it is works. Or else severe GERD condition it can be given up to 24 hours. So it is a recommended thing. Hope you people got it. And another thing, so in category B, we need to understand one thing. In category A, capital letter, if they didn't write in a capital letter or the sign of the doctor is not there, they are errors. Because you people have to remember one thing in medical field, if something it is not documented, it will be taken as it not happened. Even the patient is getting better. I saw in the real time one medical legal case that particular person, staff nurse, got a summon because of that thing. So just because of she forgot to put on one signature. So it was described according to the IPC, Indian Penal Code as well. It is in the Medicaid because in any other department, it is error is happened. It is taken as an error, but it is we are dealing with the human lives. It is not. We won't be getting the excuses. Okay, and if they are writing for tablet TAB, they are not writing. They are comes under category A because the doctor sign is not there, or they didn't write in the capital letter, or they didn't write in the proper abbreviations, accepted abbreviations. That is not going to cause any error. That should be an ideal prescription practice that is not followed by a physician. So that is an error that need to be insisted to the physician according to the hospital policy, because the medicine name should be written in generic and the medicine written should be in a capital and it should be legible, not supposed to be like this. And to check, do not use abbreviations. So because for medication errors, if you want to use standard guidelines or if you want to get standard ideas, you can refer the thing. So here NCC MERP, the National Coordinating Council for Medication Error and Reporting and Prevention. So it will be having a limited information, but it is worldwide accepted one thing. So which is revised in the year of 2015. I am showing you the guys dangerous abbreviation which is listed latest. Okay, so we can tell that sir anyway the staff is going to understand and the patient is going to get treated. So what will be happen with this kind of units? Because the drugs which is given in the units, most of the drugs are high risk drugs. So anyone can you tell me that what is high risk drugs? Guys?
Drugs
Which
causes
has
in death and severe
drugs
side
which have
effects for
Your voice is not clear.
Masons.
Have narrow
Yes.
Can you speak bit louder?
Warfarin drugs.
Some
Some
drugs
drug wasn't there.
Blood thinning drugs.
The drugs which has narrow therapeutic index
okay.
and requires monitoring regularly.
Okay, but I'm telling you, so you people telling that what are the classes or what are the drugs will come under the high risk drugs, but you need to understand one thing.
Steroids.
I'm telling
Drug
you,
which
you need to understand one thing. There is an yearly updated high risk drugs and high alert drugs. There is a two different category. So it is kind of a look alike, sound alike. It is in term, there is a difference. So I'm showing you guys in the that is in PPT itself. So under high alert medications are bear a heightened of risk causing significant patient harm when they are used in error. Okay. So that medications will come. So there are medications you told, platelet drugs, so warfarin, so coagulant drugs, and so many things. And the insulin and all that will come under this category, high alert medication, because these drugs are having high sentinel events. If these drugs are used not in an appropriate manner, it can cause a severe harm to the patient because the insulin is not handled properly by the professional. It can cause the hypoglycemia and it can lead to the shock also. Or it can lead to the lethal conditions also. So you people are aware about that. And then it will having so many criterias. So because it need to be have double verification, it not supposed to be handled by a single staff in order to avoid these kind of errors. And another thing, it is high risk medications. So in this high risk medications, you should understand that the drug which is having narrow therapeutic window or index. So the narrow therapeutic drugs are like a cardiac drugs, which is having very specific action, but it can cause a potent side effects like a digoxin or a vancomycin, and the drugs like which is having more side effects, phenytoin, so many things. It is everything. It is available in the IMSP website. You can note it down. So and can can go through later because we are running out of time. So I'm telling you guys how to overlook and look alike and sound alike drugs. These drugs also will come under high risk medications. Why? Because these drugs can cause the errors very easily. So either by their looks or by their sound. Okay, but can anyone name some drugs which can look alike or sound alike in your experience or ward rounds you have seen or faced the issues for the look alike and sound alike? Anyone of you? Okay, Risma told prednisone and prednisolone, rifaximin, rifampicin. Yeah. So this particular drug it is in my I'm going to highlight this point because the one drug it is hepatoprotectant drug, rifaximin, and another drug it is anti-TB drug, so rifampicin. So in the patient is having the pan drug resistance. Are you guys aware about the resistant patterns which is um, getting in the trend nowadays? Any one of you? So I'm telling you. So when the pan drug resistant it is coming, so the pan drug means no drug, all the drugs to the particular bacteria isolate or fungi isolate, it is become resistant. There is no drug of choice is available. So in that category, what we will be doing as a clinical pharmacologist or as a person, so what they will be doing? In any one of you having any idea? So you can put your thought. Yeah.
Sir, we will add clavulanic acid like that.
So
One
yes,
more
that
drug.
will work for an basic resistance, but I'm speaking about pan drug resistance. I'm giving you small overview. So there is so many resistant patterns, but it is a very worst topic. I'm giving you major things. MRSA, methicillin resistant Staphylococcus aureus, and vancomycin resistant enterococci. And another thing it is multi-drug resistant. So in this multi-drug resistant, where it is a basic one-line definition. It is when the microorganism is resistant for 3 different antibiotic classes or more. So if it is in a resistant for 3 or more antibiotic classes, complete antibiotic classes should be resistant. If the one drug, example, meropenem is resistant, but imipenem is sensitive, means it is not going taken as an carbapenem resistant. Carbapenem resistant enterococci is also there. In that case, extensive drug resistant, and another thing it is pan drug resistant. So pan drug extensive drug resistance means only 2 class of drug it will be available to treat the particular infection. So multi-drug resistant, 3 or 4 classes will be resistant, but in extensive drug resistance, you will be having only 2 classes remaining to treat the infection. But in pan drug resistant, you will be having no other option. That time they will go with the most higher end antibiotics, the drugs like colistin, ceftazidime avibactam, and then they will be going rifampicin or another things like we can say that people most commonly won't be aware about those things, but I'm telling you. So and then Astrionum and Zavicefta, because they will be looking into the site where the infection is happened. Either it is an respiratory tract infection or it is an infection related to the abdomen, or it is the urinary tract, or it is a bloodstream infection. So that and all they will consider, and then they will go with the best option which is available, because rifampicin it is not only the anti-TB drug, it is an antibiotic basically, but it is having more toxic effect. Combination therapy will be recommended in these cases, but we can go back to our core topic, the errors. Okay, guys, and next our category, it is category C. I'm telling you guys, prescription errors, prescription appropriateness review. It is the major core competency for a clinical pharmacist to become an clinical. You should excel. You should become very very much knowledgeable or reliable source on these areas. So I'm telling you. So what is in prescription appropriateness review? So that it will consider all of the aspects of the prescription. So it will take the 5 rights, but basically I'm telling you guys with showing the prescription. So it doesn't write drug. So they should write the proper drug name, and they should write the right dose. They should mention the what is the dose over there. After that, they should mention the route, either it is an IV or an IM and all, and they should write the frequency, and they should write the remarks if there is any drugs. If there are drugs like an ticoplanin or an polymyxin B, that drugs need some remarks in the aspect of loading dose or step downing. So after ticoplanin, 400 mg BD into 3 dose, it should be followed by 400 mg OD, or according to the patient with creatinine clearance 200 mg OD. So that remarks can be written here. And the doctors, because this prescription, it is for an authorization, so for this authentication. So we supposed to in any aspect in order to intend that particular drug, or in order to legally it isn't valid thing. So without a prescription prescriber signature, the particular order not supposed to be carried out forward. Okay, so the name, sign, and registration number, but here it is not legible, because they should write their full name and the registration number should be visible properly. After that, here you can see clinical pharmacist signature. So it is in one hospital medication administration record. I don't want to mention the thing. It is clinical. Why we our signature is here? Because like doctors, we need to take a review on the patient medication every 24 hours according to the patient current condition. What and all the escalation should be done or de-escalation can be done, or the medicine should be unnecessary medicine should be stopped. So here we will be signing that we will be reviewing that while taking that first order. So we will be signing in that particular thing. Okay, this particular order is legible. Okay, it is correct. You can go forward. And then for antibiotic start date and time should be there. In order to mention that if to control the duration of action or irrational, avoid the irrational use, we should mention the start date and time. So we can mention. So if in the case example, so Merapanam, it can be given from 7 to 14 days. But according to the patient condition, we need to mention day 10 in the first day it is. So in that particular thing, so while transcribing, the transcription error won't be happen in this case, because if they are transcribing that particular order, if they are mentioning that day 1 again, so it will be again it will be collapsing for the person who is giving the medicine. So these are all the things we need to see. Hope you guys clear. Can anyone answer, or I'm going a bit faster, or you didn't get any points?
So we are
Guys?
getting the points. No problem, sir.
Okay, thank you. And these things, it is that, and administration time should be also mentioned by the doctors. That is a prescription practice, because they only knows for. Can any one of you unmute yourself and tell me the patient is not on catheter? Example, urinary the patient is not on Foley's. The patient is not on urinary catheter. Can we give diuretics in the night to the patient? Is it recommended? Or if it is not recommended, what is the reason?
It is not recommended, sir.
What is the reason?
Because it will let that patient pee a lot at night.
So you should
Frequent urination. Frequent urination.
So you should so what you have told the point, but you should be more specific. So I told you why, because the patient, if it is not in the Foley's, it can be given BD, but not should be administered in the time. So for every drug, there is a standard time. So for warfarin, there is a standard time. For clopidogrel, it should be given in the day. So in the afternoon. So for the some drugs, so the like diuretics, it should be standard time. It is the patient is not on Foley's, it should be given 10 a.m. 4 p.m.
BD, sir. Yeah, sir.
Yes, but 10 a.m. 4 p.m. it should be given. But if we can't give that 10 a.m. and 10 p.m. or 8 a.m. or 8 p.m., we can't give like that. Why? Because the patient will be restlessness. So there is so many things you people aware about those things. I'm not digging it in the deep. And another thing, transcription error. Can anyone of you can tell me that what is transcription error? In the chat box is fine, I think. So guys, you can tell me. So if you are wrong, you will be knowing it, or if you are, it is just an open discussion. So it will be more good if you are discussing actively. So okay, without wasting time, I'm telling you people, transcription means so copying that order. So from the progress sheet to medical administration record. So the particular order remains in the progress sheet. It is not an order. It is just an it is not a proper medication order. It's not supposed to be administered to the patient. So after written in the MAR chart, it can be taken for the treatment purpose, unless otherwise the patient is having emergency conditions. So now another one thing, it is transferring transcription from progress note to MAR chart. Or if the patient is need any department specific consultation, that I have mentioned here as a cross consultation. Either the patient need a nephro consultation or a cardio consultation. So their recommendation need to be transcribed to the MAR chart after the primary team decided whether it is necessary or not to the particular patient. So the final decision will be taken by the physician. So we can't go randomly and ask to the physician, sir, there is a transcription error. So in cross consultation sheet, they have mentioned one drug, but that is not transcribed to the patient. That kind and another thing it is for transcription error, another thing will also be there. If the patient is taking current medication for hypertension or diabetes, or the patient is having some other conditions, so the patient is on some medications while on admission, so that indication should be treated. Should be treated, but there is no compulsory that the same drug should be followed based on the patient condition, because the patient is hospitalized in order in aspect of patient speedy recovery or the patient severity, so they will be changing it. So in that time we need to understand that okay, we need to see that either the indications of the patients is treated or not. Okay guys, and so I'm again telling you, so that category C, it will comes as an transcription error, because one particular order which is transcribed as an another order, it will cause an very drastic things. Because I'm showing you guys the tablet Ambraxil, it is an mentioned as an 30 mg PO BD. So imagine that this particular thing is transcription order. So but they didn't mention that mg. So it can cause the error, because the staff who is coming to the hospital, they didn't know anything, so they can give something else to the patient. Okay, because in my experience I have seen that the staff nurse who is given the Lasix injection Lasix to the patient orally. So there is so many things can happen, because they will be having so many patients to handle, 7 to 8 patients in their shift. So there is a chance of error. And then tablet Monteir effects. If you are seeing in this aspect, they have mentioned only one tablet. So is this error or not? Can any one of you tell me? I have told one point regarding this in the earlier. Guys, are you following me? Hello? Can put it in the chat box if you want to convey. So okay, if no one want to answer, so I'm going with the things. Okay. Does anyone want to answer now? So okay, so we can this Monteir effects, it is a specific brand. So that this is combination of two drugs. So which is Montelukast 10 mg and fexofenadine 120 mg. So and you people need to aware about one more thing, that there is a combination of these two drugs available in another dose, but not in the same brand. So when they have mentioned this is an actual error, they should mention the dose, but this is comes under category A. Okay, but it is not having the capacity to cause an error. So you need to understand, but you can see here the tablet doxolin, this they have mentioned only 400. They didn't mention either it is in 400 ml or 400 mg. So what it was. So this is in wrong order. So we need to escalate it to the staff and then ask the doctor to rewrite. This is the one of the error. So on category E. So and then the error occurred resulted in the need for treatment or intervention. So example, so injection diclofenac, it is given in the IV form. So the patient got, what will happen? So if the injection diclofenac given in IV, what will happen? Any one of you? Guys?
Cardiac arrest.
Pain at the site of it.
So yes, the cardiac arrest will happen. So what is the primary reaction in this case? So due to its particle size, so big particle size, it will produce the cardiac arrest. The main thing, it is one word, it is there. You can answer that. Either it will produce anaphylactic shock or not. Guys?
Yes, sir.
Okay, and another thing, it is for this category E. So we can understand, we should understand that one more thing. So in this case, I'm giving you guys example. If the patient is having the missed dose of the drug, or the patient didn't receive the loading dose, so that particular things will comes in this category. Why? Because error occurred resulted in the patient need for treatment or intervention. Why? Because the patient got an infection, the patient came to the hospital, but the patient missed the dose or the loading dose is not given, means the patient hospital state will prolong. The patient, that is the need of intervention. So once we identify, okay, so it was not seen by the clinical pharmacologist by the 24 hours, it was addressed, that issue was addressed in the 48 hours. That time we are telling that, sir, the particular drug, either it is an anidulafungin or the polymyxin B or it is meropenem, they didn't given. So, but the patient outcome, the patient prognosis, it is poor. So that time, what we can do as a clinical pharmacologist? Okay, the patient treatment is ongoing. So what will be your recommendation? Can any one of you can answer this? Because the patient is missed dose, the loading dose is missed. The patient prognosis getting delayed. The patient better outcome, it is getting delayed. So as a clinical pharmacologist, what you will suggest or what is your point of view? It's okay. So many of you are student here, so I don't want to put you people in a pressure. I'm telling you. So we can tell to the physician if the patient inflammatory markers like procalcitonin or the patient D-dimer levels and the patient another things were not improved. So after the 3 days of the treatment, if it is not improved, we can ask them to stop and restart the particular treatment. So the particular loading dose should be given. After that, it should be followed, but it can de-escalate once the patient is getting improved based on the duration. Hope you got my point. And another thing, it is category D. So why I didn't mention the category D purposefully, I didn't mention. So it will comes under the monitoring error. So it will release on us. Can any one of you can tell me that monitoring error? What are the things will come under the category of monitoring error? As we discussed here, this is one of major error as in monitoring error. What it will be? Guys, you people were active so for so many times. So can anyone of you answer?
Potential adverse effects, sir.
Yes, it is one of the thing. Another thing is there
Prolonged
any
usage of drugs
Interpretation.
causing elevated blood glucose levels or
okay, but I'm telling you guys, there is so many monitoring levels by a physician, by a nurse, as a clinical pharmacologist. Okay, you people are telling that it is good, but as a clinical pharmacologist, we are having some monitoring measures. If the physician miss, we not supposed to miss, because every day we are taking the prescription review. We need to address that, or we need to monitor particular thing. So can anyone of you answer in that monitoring error?
Drug allergies.
Lab parameter.
No. Any other thing? Yes, it is a thing. It can cause certain monitor error, but it will be labeled in the initial assessment or it will be confirmed by us, but it is not a monitoring thing. The doctor won't be prescribing it, right? So it will be like an error which need to be prevented in the initial stage. So not in the day by day basis, right?
Drug allergies can be monitored.
Okay, another thing. Any other things, guys? Okay, I'm giving you the paper answer.
Elimination, renal function.
Yeah, that was the point I was expecting from the you people, because as a clinical pharmacologist, we need to look for the dose optimization. The patient blood levels, if the drugs like a narrow therapeutic drugs, which is in you people addressed as an high risk drugs. So that vancomycin blood levels should be monitored. If the patient is receiving the vancomycin, the patient vancomycin blood levels should be monitored in order to ensure that there is no toxicity in the aspect of vancomycin. Or if the patient is having the impaired renal function, that time renal dose should be adjusted for the drugs like piperazine tazobactam or meropenem or polymyxin B or javisepta, ceftazidime avibactam. Any other thing? If see missing something, you can add on it. So here in this right dose, we have mentioned that subtherapeutic dose or a supratherapeutic dose. Renal or hepatic dose adjustment. So renal or hepatic dose adjustment thing also it comes under this point only. But for the hepatic dose adjustment, how frequently we are doing or for how many drugs it will be needed? If it is needed, how you people will be doing? Can anyone answer that? Guys? Okay. Okay, guys, I'm telling you, for hepatic dose adjustment for like creatinine, we are getting the creatinine values, right? There is no internal markers for the liver. So with that we can, because the creatinine which is valuable for the 24 to 72 hours, which is, it is an daily the patient creatinine level, it can be changed. So based on the clearance level. Okay. But the for hepatic, there is no internal particular marker. It is not available to read the particular hepatic clearance in a daily basis. But there is an hepatic dose adjustment based on the patient's blood flow to the hepatic, and then so many factors are there. But it is not recommended for the all people, and it is not quite feasible for all the patients also. Okay. And I'm telling you guys again and again, it may be look like a simple thing, right patient, right drug, right dose, right route, right frequency, right documentation. It has having all the things which one clinical pharmacist should have a clear cut idea about it. Because in right patient, so we will be preventing three things. One, it is an international patient safety goal. So that the patient not should be changed, because the shift is getting changed. If they are giving the handover to the next staff, as in just mentioning the patient bed number or name, so they can, in the confusion, they can administer one drug to another patient. So on, if there is an, we have seen that some news that one particular surgery site it is deferred and all. So the patient it is getting changed, and then administration error happened in that particular case, and right drug. So in each and every 24 hours, the drug should be reviewed by the physician and clinical pharmacologist based on the patient current symptoms, diagnostics, and lab values. So here you people should understand three things. The patient WBC it is getting down. So the patient neutrophil it is in a good condition. We need to understand that one thing, it is if any of the indication it is not treated, or if the some drugs need to be stopped, so that particular things should be informed or suggested from our end. Okay, guys. And category F, G, H, I. So that category I we have discussed earlier that injection diclofenac or if any kind of allergic drug it is administered to the patient, it can lead to the anaphylactic shock. It can produce the death. And this most probably from A to E only it will be happening in the case of medication error. F, G, H and all very rare. And since we are running out of time, I'm moving forward to our case discussion. So here it is whomever is a clinical pharmacologist aspirant. So this will be a very good discussion for you people. So I'm requesting you to participate very enthusiastically. So we can finish it within a 5 to 10 minutes. So I'm giving you the thing here. So scenario and 71-year male came to cardiology OPD with complaints of lower limb weakness for 2 days. So the patient is having an surgical history of coronary angiogram. It is done and planned for CABG. Okay, and the patient doesn't have any fever or a chest pain, or the patient doesn't have any vital abnormalities. So can any one of you can guess what will be? So it is, I'm giving you the clue. It is a drug induced disorder. So can any one of you can guess some things? And I'm giving you more clues here. So wait a minute, guys. The image is not able to zoom. I'm projecting from here. So on discharge, patient hemoglobin, it was 15.8. So the patient had the thrombocytosis. Okay. And RBS, it is 121. Urea it is 33, creatinine it is 1.6. So these are the lab values of the particular patient. This is the discharge medications. And while analyzing the drug interaction, you should be more cautious. I'm giving you the outline so that people can correlate. So if you are finding out any drug interaction, so first you should understand that if you are telling that some any other interaction, so that should be administered in the same time. So that the half-life of the particular drug or the weight and risk ratio of the particular drug should be justified by us to change the drug or change the any other drugs. So, but can any one of you can guess the thing? So, what will be the drug-induced disorder by after this medication? So, I'm taking you to the thing here, the drugs which have taken by the patient. Can anyone can answer or can I proceed further? Guys, are you there?
Hemolytic
Yes,
anemia, drug induced.
Hemolytic anemia,
No.
sir.
No. Good things, but you can give it a try. Another thing also. Anyone else? So shall I proceed? If you want me to proceed, I will. Because already we are running out of time. Your organizer telling me we are running out of time and all. Can anyone tell me that something? Guys, you can post.
You could
No
proceed,
idea,
sir.
sir.
Someone was telling something. Come again. Okay. Guys, I'm telling you that on that particular day, the patient came to the OPD. So the patient was treated with the following same medicines. Along with this 9 medicines, the patient was prescribed with an clopidogrel. Since the patient had an thrombocytosis complaint on the discharge, the patient was discharged with the same thing. So they have given the painkiller, so some paracetamol. So in order to for the lower limb weakness, they have given. But they so while I'm checking this in a scenario, so I was in my night duty, so that junior resident came to me and then she was telling to me, so the patient with so and so complaint. So I don't have much of an idea about that. So I'm suspecting is some drug induced issue. So put your view on this like that and all. So for that time, patient came to ICU. So that particular time, the patient came after 1 month. So the patient was prescribed with clopidogrel and paracetamol for the lower limb weakness. But the interactions where which was undergoing to the patients is very pathetic because the patient is receiving the rosuvastatin 40 mg Hs. Since the patient doesn't have the high cholesterol levels, but in either two anticoagulant drugs were recommended so as per the standard guidelines post CAG. But here we need to understand one thing. They have ordered the clopidogrel as well, which is a blunder mistake, but that is not reviewed by any kind of clinical pharmacology since it is an OPD basis, and they have given the paracetamol also. And I have checked while giving the intervention to the physician in the lexicon, but I'm showing it the in two different things. Okay, first, while we are telling that errors which is happened in the two things, as like I mentioned, we need to ensure that it is an administered in the same time. Rosuvastatin and ticagrelor it is administered in the same time, and ecosprin is also administered in the same time. Okay, and it is a nitroglycerin which is administered in the morning, so it is having the interaction with ticagrelor, and amiodarone is also administered in the same time, and torsemide is also given to the patient, which is in potassium sparing diuretic, and sorry, not a potassium sparing diuretic, it is in loop diuretic, and eplerenone, it is Planap 25 mg, it is eplerenone potassium sparing diuretic, which is given in the afternoon. So nicorandil, which is twice daily, and Renozex, it is twice daily. So and what we have found on that particular time, even the primary team of the patient is also not arrived. But we have come to the conclusion it is a drug-induced rhabdomyolysis. The patient had a myopathy. Since the patient is experiencing the patient muscle mass, the muscle fibers, it is getting eliminated into the patient creatinine, and so it is eliminated from his body. So that patient is not able to lift his leg after 1 month. So that time I have checked in the lexicon that ticagrelor and sorry, rosuvastatin and ranolazine, which can cause a myopathy. So I'm showing you the guys. So amiodarone and torsemide, so which is not an possible error. So amiodarone and torsemide, which is having a thing, but it is not that much thing. So we can see the management also co-administration of amiodarone. So it should be avoided. So we can give 1 hour before after. So another thing here it is amiodarone or eplerenone. So which is an cytochrome 450 3A4 inhibitors. So which can cause the increase of eplerenone value. Okay, so the potassium sparing diuretics level is increased because of the one interaction in the evening, in the night also. This sorry, which is having two different things. It is administered in the afternoon and another drug is administered in the night. So it is not a possible interaction. And clopidogrel and rosuvastatin. So this particular drug, when the patient is having muscle weakness due to ranolazone, so which is prescribed previously to the patient, ranolazone and rosuvastatin, and this pathetic combination of clopidogrel and rosuvastatin increased it is more. So here you can see this rhabdomyolysis has also occurred rarely. Now myoglobinuria. Okay. In this case, I have while checking on the exam, it should be given minimum 4 to 12 weeks. So the patient received that particular combination on for 1 month, and the patient came to the hospital, and the patient was, because here we can see the management that some other guidelines said that not supposed to exceed the rosuvastatin 20 mg per day, but the patient dose actually prescribed it was 40 mg per day. So 40 mg Hs it was prescribed for the patient. So it made the condition more worsened. Creatinine kinase is markedly elevated. The options of it is myopathy are suspected or diagnosed. So, and I'm telling you guys, what were the findings with the particular patient?
Excuse me, sir.
Yeah.
Sir, which website were you checking the drug interactions? Can you
So
please
guys,
name
I'm checking in the Medscape as well the drugs.com because right of now I don't have the lexicon or micromedex things. I'm recommending you people to use standard things like micromedex or lexicon. If you don't have that option, you can come to drugs.com or Medscape. Okay. Here
Can
you
you please
can
repeat
also
the standard
yeah.
ones?
Standard
please
one, it
repeat
is a micromedex or a lexicon. It is more or less, it will be more good. It is accepted by the doctors.
Micromedex and
Lexicon.
lexicon.
Okay. And then here you
Thank
can
you, sir.
see in the, because if you are referring in any other things, you can confirm once or twice. Ranolazine and rosuvastatin, it can cause the increased risk of myopathy. So that condition which is worsened, this particular thing, the clopidogrel and another thing, rosuvastatin. But here we can see that I have added the rosuvastatin also and clopidogrel also, but we didn't find it out as an major interaction or even monitor closely also. Okay. But that's why I'm telling you people which is followed by your hospital doctors, you should or you can make the standard reference as an articles and all drug induced rhabdomyolysis findings and all. And I'm telling you, so patient blood creatinine level, because the patient came with the from the emergency department, patient blood creatinine level, the blood samples were went that time. So while we are discussing, after 1 hour, the reports came. So on the patient, blood creatinine level was 7.6 milligram per deciliter, and urea it is 320 milligram per deciliter, and creatinine phosphate kinases. So it is 270 unit per liter. So can anyone of you tell me that what is the normal range of urea in the patient, healthy